You might see the transcription on the right-hand side of the Teams window. If you want to turn that off, please just click on the little cross at the top of the screen, and that will work. That should work. So welcome everyone for the second session of NCOR Evidence Summary. The aim of this session is for Carol and myself, so Dr. Carol Fawkes, who is with us, and me, Dr. Jerry Draper-Rodi. We both work at the National Council for Osteopathic Research, sorry. And the aim of these sessions are really to provide a time for us to discuss current evidence and how we can maybe use them in our practice, which might be clinical practice or maybe in education, depending of our different roles that we might have in our professional life. So today we are going to talk about two different things. We are going to look at a new guidelines that was published on Cauda-Equina syndrome and to look at what that means for us in practice. And the other one is going to look at two papers on the osteopathic treatment and management of patients coming with chronic low back pain. And we're going to see that these two papers found quite different results, and we're going to try to work out why these results are different in these two different publications. If you have any questions during the session, I would suggest to putting them down in writing in the chat. Carol will be presenting first the guidelines of Cauda-Equina syndrome, and after her session, there will be a time for Q&A. And at the end of my session, there will be a time for Q&A. So you can either keep your question and ask them verbally during the Q&A session, or if you are worried to forget your question, feel free to put that in the chat and we'll go through the chat during the Q&A sessions. So I will let now Carol taking it from there.
Okay, thanks, Jerry. I'm just going to turn off my cameras. I'm getting a kind of weak signal message on my computer. So just to preserve the quality. So thank you. I'm going to talk about Cauda-Equina syndrome, and although this may be a fairly uncommon presentation in osteopathic practice, you will see it cases during your professional life. So Cauda-Equina syndrome is a rare condition. It's estimated it affects about 2% of all herniated discs in patients, and it occurs as a result of neural compression. So let's have a look at the Cauda-Equina itself on the next slide. So as we can see, there are 18 nerve roots which comprise the Cauda-Equina, and neural compression from something like an intervertebral disc herniation or prolapse can lead to a loss of function of 2 or more of those 18 nerve roots. So Cauda-Equina syndrome is considered a potential emergency within orthopedics and other areas of practice. However, the exact timing of the surgical decompression remains controversial, but early diagnosis and surgical decompression are essential. So although the timing is discussed by researchers, it's suggested that spinal surgery within 48 hours of an individual developing sphincter dysfunction will optimize post-operative recovery. If it's left untreated, Cauda-Equina syndrome can lead to permanent loss of bowel and bladder control, sexual dysfunction, or even paralysis. So due to the serious consequences of Cauda-Equina syndrome and the suffering experienced by people with this condition, it has become highly litigious. And Markham, in a study in 2004, so quite old now, he reported an average payment of $336,000 per patient in 2004, and the NHS has paid out in the order of 44 million in the 10 years up to 2013. So that data comes from the NHS Litigation Authority, so you can appreciate how much that figure might have increased up until the present time. So who's affected? So as I've mentioned, the prevalence is low, with estimates ranging from 1 in 33,000 and 1 in 100,000 inhabitants. But the incidence is estimated at between 1 and 1.9 patients per 100,000 of population, or this translates to 15 to 31 cases confirmed in UK tertiary care centres annually. So large central lumbar disc herniation at L4 or L4-5 or L5-S1 is the most common cause of Cauda equina syndrome, although rarer causes are described, and these can relate to a range of things, including ankylosing spondylitis, chemotherapy, congenital spinal cord disorder, constipation, epidural anaesthesia, infection with things like osteomyelitis, spinal epidural abscess, or arachnoiditis. It can occur in multiple sclerosis, in neoplasms, either primary or metastatic, radiation spinal stenosis, and vascular lesions, things like hematoma, arteriovenous malformation, and inferior vena cava thrombosis. And trauma is also a cause, and there is one reported case in the literature of a burst fracture of the lumbar spine. So who is most affected? The data suggests that female gender and age above 30 years have been identified as 2 risk factors associated with Cauda equina syndrome, and it's felt that most patients affected are young to middle-aged. So on our next slide, we can have a look at the clinical presentation. And this can be very varied, and detailed history taking is a crucial part of our care to minimise the risk of missing early identification of patients with a suspicion of or risk of developing Cauda equina syndrome. So for most patients, they will consult you with increasing back pain and sciatica. They may report symptoms starting in the other leg, numbness in both legs, and then the subjective and objective sensory changes in the saddle area. So changes can be associated with urination, and these can include urinary changes, frequency changes, difficulty initiating and passing urine, or loss of the desire to void the bladder. Patients can also report abnormal sensation while passing urine and decreased sensation or lack of appreciation of having passed urine. Incontinence is also part of the presentation, so typically presenting as a kind of dribbling overflow of urinary incontinence. In some cases, it can be present due to a tumour, but in the case of a tumour in the lumbar canal or at the conus, the evolution of the symptoms can take a few weeks or few months. So the long-term monitoring and careful monitoring of patients and the progression of their symptoms is really important. But Cauda equina syndrome in these patients is a late manifestation, and it tends to imply that the tumour has grown to a large volume. So the Cauda equina syndrome cue card, developed by Greenhalgh and colleagues, and which I'll show you in a few slides, supports the essential but often embarrassing questions about bladder and bowel function and sexual function that patients need to be asked. And this is a really useful tool for clinical practice. And then if we think about our clinical examination on the next slide, there are a number of things to consider in the clinical session. So if we just go back to the previous slide. So as I've mentioned, the detailed case history is very important, and then a neurological examination and the cue cards. But if we think about the kind of things which are important when we get to the examination stage, chaperoning is important. So the role of an impartial observer present for the safety of the patient and for the osteopath or other therapist. And the chaperone should read and sign the patient records when the session is completed. So in some practices, saddle, perineal or perianal sensation can be examined. And in the early stages, the patient may have intact sensation to light touch and pinprick, although they may report some subjective change. So when a patient develops some sensory change, it may be unilaterally initially, but becoming bilateral as symptoms progress. So the sensation can be tested in side lying from the outside towards the sphincter using a gentle gloved movement or a folded tissue, or consider the use of a neurological examination sharp pin. When patients are referred to hospital and they enter the emergency pathway, then trigone sensation can be tested. And the trigone, as you're aware, is a smooth triangular region of the internal urinary bladder, which is very sensitive to stretch. It can be inserted and inflated Foley catheter, which is gently pulled with the patient unaware, called the catheter tug test. So this should produce a desire to urinate in most patients, but any abnormal deficit in sensation may indicate the neurogenic abnormality, such as Cauda equina syndrome. So other examinations which can take place in the pathway include bladder or abdominal palpation to palpate for an enlarged or percussible bladder. An acute urinary retention is defined as a palpable and painful percussible bladder. Bladder ultrasound and catheter drainage can be examined. An ultrasound scan of the bladder and then the measurement of residual volume can also support assessment for retention in the emergency pathway. So over 200 millilitres of residual volume supports investigation for retention for patients with suspected Cauda equina syndrome. Rectal reflexes can be examined, so loss or diminution of bulbous cavernous reflex, whereby the stimulation of the glands, the penis or the clitoris, causes reflex contraction of the anal sphincter, and this is also suggested of Cauda equina syndrome. And then finally, anal tone. So the anal sphincter tone can be diminished, but this has poor predictive value in practice. So for us as osteopaths, seeing patients in clinical practice, perhaps at the very first stage, the full neurological examination should include things like muscle bulk or tone in the patient, examination of their myotomes and dermatomes, the plantar response, looking for clonus, deep tendon reflexes, and then neurodynamic testing, things like the slump test and straight leg raising test, although there will be some patients where this is contraindicated if they're just in too much pain. At the end of the history and examination, clinicians will be able to classify patients according to the Cauda equina subclassification of groups developed by Todd and Dickinson. So that this will come as Cauda equina suspected, involving bilateral pain, incomplete but involving urinary difficulties of neurogenic origin, retention, Cauda equina syndrome with retention, so it's painless but involving urinary retention and overflow incontinence, and complete Cauda equina syndrome, so involving loss of all Cauda equina functions. So despite the timely intervention, sustained functional deficit is common in Cauda equina syndrome. So of the patients with Cauda equina, about 20% will have a poor outcome and require ongoing treatment and rehabilitation support. And a recent meta-analysis supports the superiority of early surgical decompression before 24 hours ideally, and before 48 hours after the onset of symptoms. So incomplete neurological deficit at the time of an operation is also associated with more positive outcomes, especially in terms of bladder function. So this form of routine data collection, including patient outcomes, highlights the importance of being able to give prognostic information to patients who are newly affected by these symptoms, but also monitoring the long-term effects of management. So when we examine the literature on Cauda equina, there are lots of atypical and rare cases reported. It's been reported during pregnancy, where laminectomy or microdiscectomy is a surgical procedure which is most commonly described in the pregnant patient when they have lumbar disc herniation anyway, but also when it leads to Cauda equina. Other cases have included patients exhibiting bilateral lower limb weakness, perineal abscess and numbness, sphincter disturbance and lower limb clonus. And classically, Cauda equina syndrome displays lower motor neuron signs in the lower limbs. So the presence of clonus in this particular case brought the diagnosis into doubt. If there's a suspicion of Cauda equina syndrome, patients are referred urgently to hospital and then for an urgent scan based on a clinician's assessment. And although a considerable amount of research into Cauda equina is formed of case reports or case series or epidemiological studies about the patients who are affected, other literature has looked at trying to improve the efficiency of the pathway and the timeliness of diagnosis for patients. So in a study by Buell et al. Based at Charing Cross Hospital, they hypothesized that the better coordination from the emergency department, radiology and neurosurgical teams could actually reduce the time of presentation to diagnosis or exclusion of Cauda equina. So they composed a team of senior emergency department, house officers, registrars, consultants, people who were at the coalface of dealing with patients with this disorder. And they were asked to lead a quality improvement project evaluating current practice for patients with Cauda equina at Charing Cross. So they tried to look at the factors which were actually delaying diagnosis, and they wanted to design a new sustainable and cost-neutral intervention to expedite the pathway. The aim of this quality improvement project was basically to reduce the time to diagnosis by 25% within a 6-month period. And Charing Cross was an ideal place for this because it receives a significant number of patients with suspected Cauda equina syndrome. So the improved work synergy between the emergency room, neurosurgery and radiology departments resulted in MRIs being ordered much earlier in the patient journey. So it ensured early consultants' assessment in the emergency department. It allowed them to order MRIs prior to neurosurgery review, and then they could communicate their assessment over the phone to the radiology team. So this much more streamlined approach had a significant reduction in time. So patients were actually seen within 3 hours, and they had a 36% baseline improvement in the patient flow through. So this commitment to improving patient care is likely to have a much more positive effect on patient outcomes. So just to conclude, you can see, I mentioned in the last item on this slide, the cue card to assist patients. So on the next slide, you will see the first thing, which describes the common back pain experienced by patients. And then on the second slide, you will actually see all the warning symptoms. And this puts the warning symptoms into a language which is much more comprehensible to patients. I think sometimes we need to understand that health literacy amongst patients can often be quite low. So we may be asking them things like saddle anaesthesia, but actually asking them questions about activities which are much more meaningful to them is more likely to elucidate where there are problems occurring. And Jerry's added the QR code here. So this will allow this particular cue card to be downloaded, and it's available in a number of translations. So for patients from a variety of different backgrounds to understand what's happening if English isn't their first language. So I'm going to stop talking there and hand back to Jerry, who will talk to you more about low back pain.
Thank you, Carol. Maybe before moving on to low back pain, do you have any questions or queries about the Cauda equina syndrome guidelines that Carol just presented? All good? Fab. Okay. So we are going to move on to the second presentation, which is about low back pain and osteopathic treatment. So as I'm sure you're all familiar with, low back pain is a very common presentation for us in clinical practice. So the latest data we have from the UK was from Plunkett et al., which is one of the NCOR publications, and we found that 81% of patients attending treatments were for MSK reasons. A bit older data, a third of them were coming primarily for low back pain. And if we look at the PROMS data that a lot of osteopaths are helping to, are helping with and collecting data in their own practice, what we see is that low back pain is a very common presentation, which might not be the primary reason why they come to see us. They might be coming for another symptom, which might be their primary symptom, the main reason for them attending. But low back pain is around 64% of them having low back pain too. So this is a very, very common presentation for us that we see in clinical practice. And most of the patients coming to us have persistent symptoms, i.e. what we used to call chronic pain or pain for more than 12 weeks. So that's a very common feature for us in our patients. I've just mentioned the NCOR PROMS. We've had now more than 7,000 observations from patients in the UK. So if you want to take part and to start collecting data in your practice, be aware that it's free and we provide all the service. You only have an inverted comma to invite your patients to take part. And if you want to do this, you have the QR code to have more information on the NCOR website, or you have Carol's email address and you just need to send her your GIOSC registration number and she will send you all the information for taking part. So going back into low back pain and osteopathic clinical practice, when patients come to see us, usually they have pain, and here I'm just using VAS as an example, and they have pain, and when they come back for their second appointment, they feel much better, and we've done a great job, we're very happy. But if we try to work out what happened, why are they getting better, what are the things that we have done that are helping them, then that's where doing a clinical trial can be helpful sometimes. So I'd like for us to look at two papers that tried to look at osteopathic effectiveness for patients with chronic low back pain. So we have this paper from John Licciardone in the US, and they looked at, again, in this population, the impact of osteopathic treatment. What they did is they compared osteopathic treatment, osteopathic manual treatment, I should say, because it's in the US, so sometimes it can be other than manual, but here it was really osteopathic manual treatment. And they compared that with ultrasound therapy, which I'm sure you're aware is not efficacious for the management of low back pain. It's very small. I'm not really expecting you to read that document, but I was just putting that there to show you a little bit about the complexity of the design of their study, but also the number of participants that were included. And I can't read from where I am now, but there were something like 400 or 500 patients in total, I think, included. So it was quite a large trial, which is not very common in osteopathy. And they found very good positive results for osteopathic interventions. The treatment effects were large, which is something that is very difficult to find. Usually when assessing an intervention, we would find small to moderate effects at best. Here they had large treatment effects, which is really good, and which were clinically relevant, the findings, which means that if a patient was receiving that sort of treatment, they would notice a change that was meaningful to them rather than to a clinician or to a statistician. It was really for patients that meant something that was worth doing. And because low back pain is, there are lots of confounding factors, which we might call psychosocial factors and things like that, they looked whether there were differences between the different groups that could explain why a group was better than the other, and trying to adjust for these differences, they found that osteopathic treatment was still quite effective. In fact, the odds ratio was very high, nearly 3, which is very high for treatment. One thing they did find was that patients who didn't have depression were more likely to respond from osteopathic treatment. So this comorbidity of depression was a factor that was affecting the prognosis of patients. They were less likely to recover if they had a comorbidity of depression. So in that paper, they found that overall osteopathic treatment was effective for patients with chronic low back pain. Now, I'd like to present a second paper, which looked at the effect of osteopathic manipulative treatment compared to sham treatment on activity limitations in patients with non-specific subacute and chronic low back pain. So here, as you can see, one of the outcomes were activity limitations, so maybe a little bit more around function, when the first one was more around pain. So again, a big trial that was published last year in the JAMA, so quite a big journal, and they had 400 patients who had an average of 14 years of low back pain in both groups. Their pain levels were not very high. It was 4 out of 10 or 40 out of 100. And their disability levels were, again, pretty low, 30. And their experience with previous treatment was similar between the groups. So to start with, we had a group that had moderate pain and moderate function impact. Both groups received on average 5 sessions, so 5 sessions of osteopathic treatment or 5 sessions of sham osteopathic treatment. And what they did in the osteopathic treatment is they had predefined areas where they had to assess, and if there were somatic dysfunctions found, then they would be applying treatment. And if no somatic dysfunctions were found, then they would move to the next area. The area that they would be working on were the talocrural joint, the root of the mesentery, diaphragm area, lumbar spine area, sacroiliac, C1, C2, or no, C0, C1, and TMJ. And as I explained, they would look for one area. Is there somatic dysfunction? Yes, then provide treatment. If no, then move to the next area. So that was the way it was standardized so that they could do similar thing between the OMT and the sham group. In the sham group, because one thing that was quite important was that patients would be receiving the same amount of attention, whether having osteopathic or sham treatment. They received brief light touch, and I think the clinicians had to count backwards in their head so that they were trying not to have any attention to provide treatment in both supine and prone positions. And they would be doing this on feet, legs, knees, thighs, pelvis, abdomen, chest, shoulder, neck, and cranium, because obviously it needed to be, I think it was 30 minutes of treatment for each session. So what they found in that paper was that they measured outcomes at 3 months and 12 months, which is quite nice because obviously we are looking at patients who've had pain for 14 years. So if we are looking at a change, we are hoping to have a change that is going to last in time. And what they found was that the disability improvement was slightly better in the osteopathic treatment, but it was below a clinical meaningfulness result, i.e. the difference was too small for patients to notice a difference. And the same happened with pain, where both groups improved, but again, below what would be meaningful for a patient to notice. And that was the same for at 12 months, where disability was still better in the osteopathic treatment, but below what would be meaningful for patients. And the difference was similar in both the osteo and sham treatment, but both were below the meaningful difference. They didn't notice any difference in quality of life, number of duration of sick leaves, number of low back pain episodes, or healthcare use, including medication. And there were no serious adverse events in both interventions. So their conclusions were that non-specific OMT effects related to practitioner-participant relationship, differences in healthcare providers' bedside manners, and treatment credibility could have contributed to the differences we observed. So I think that's quite different. Interesting. If we look at paper 1, they found large treatment effects, which is quite uncommon to find in the literature. And then paper 2, they found no difference between osteopathic treatment and sham treatment. So, we can start wondering why are there diametrically opposed, findings in the research? And one easy answer would be, there's that paper, but in 3 months' time, there'll be another one saying the opposite, which, there might be an element of that. But I think there's also something quite different between the two papers, and I'd like to draw your attention on these aspects now. So in research, we often use two different words that sometimes might be conflated with each other, which are effectiveness or efficacy. And whether we are looking for one or the other might be calling for different methods. So on this little diagram, you have on the left-hand side what is called explanatory trials. The explanatory trials are usually a trial where you might have a placebo group or a sham intervention. So you try to do something that is like osteopathy, but you remove what you think is the active ingredient of the treatment. So if you think the active ingredient is something about the technique, you will remove that specific object of the intervention to try to measure how much difference we find. For example, let's say you are looking at manipulations, HVTs. You might want to do HVTs with a pop versus HVT without a pop, and to see whether you notice a difference, which might be on a specific mechanism like physiological differences, or it might be on patient outcomes and things like that. In that case, you would be comparing your treatment to a placebo group, and that's what we saw in the second paper, where they had somatic dysfunctions and then doing osteopathic treatment or sham treatment. And what you are trying to measure is the difference between these two groups. And this difference between the two groups is what would relate to what we call specific effects of the treatment. So we're just measuring a tiny little thing of the overall effectiveness of the whole osteopathic intervention. Sorry about the noise, but if we see osteopathic treatment as a complex intervention into which we have lots of different tools, including hands-on techniques and including reassurance, education, empathy, all of that being the different aspects that are included in our intervention. Here we are only looking at the specific component of the hands-on, so of one of the tools that we use with our patients. And that's why if we look at effect sizes or difference between groups, we have to be expecting smaller differences between the groups compared to what is on the right-hand side of the diagram, pragmatic trials. And that is what we saw in the first paper in Lichardone, where we compared two forms of treatment. So just to remind you, he compared osteopathic manual treatment with ultrasound treatment. And what we do is we take two treatments. Ideally, we wouldn't compare with a non-efficacious treatment because that's not super helpful to us. We would compare to another form of treatment that is helpful to patients. So it might be Pilates, for example, for back pain, or it might be CBT, whatever sort of treatment that patients find effective, and we have data suggesting CBT or Pilates or whatever is helpful for patients with persistent low back pain. And then what we are measuring for both treatments is all of the different components that are included in the effectiveness of that intervention, including the specific effects, like it was measured on the left-hand side of the slide, but also non-specific effects or contextual effects related to our, patient therapeutic alliance, related to the trust they have in us and our communication skills, the reassurance and the education we provide, self-management advice, and all of that is also included in there. And also the natural history, which, to be honest, there's not much in persistent chronic low back pain, but all of these sort of potential differences. So now looking at these two models of trials that exist, we can start to understand why the first paper, Licciardone, found large treatment effects, because it was including all of the different ingredients that we have when baking osteopathic treatment, to use my sort of bakery metaphor. And when on the second paper, they were looking at just one of the ingredients of the overall intervention and trying to see whether removing that ingredient was making much difference or not. So based on Licciardone, what we can say is that osteopathic treatment, overall osteopathic treatment, is a helpful intervention to support and help patients with chronic low back pain. But if we look at NCOR paper, where they compared osteo versus sham, we know that probably the hands-on is not the main ingredient of our intervention. And there might be other aspects of what we deliver through education, reassurance, that may be more effective. The third possibility is that in NCOR's paper, the placebo intervention was not well done, and therefore it was too similar to the hands-on component and not good enough to see whether there was a difference. My bias, I think it was a very good placebo. I know quite well the team who worked on that, so I quite give a fair amount of trust in that placebo, but nevertheless, it is still a possibility. I don't think that one paper is enough to answer a question, but it gives some sort of food for thoughts. Papers are never either fully explanatory, like on the diagram, or fully pragmatic. There's a spectrum of trials. And I've just put there in the middle of the slide this sort of figure that is a tool called the Preci2 tool that is used in research. I don't think it's very useful for us as clinicians, but I'm just saying that there, it is used in research to assess how much a trial is pragmatic or how much it is explanatory. And just to say, it's really a spectrum, and some trials will have features of pragmatic and features of explanatory, and that's quite normal. But basically, these two papers I presented were each on different end of the spectrum, and I think that's why it was quite useful to look at these that have quite different findings. Finally, I just would like to recap a little bit what I've said. If we look at the overall effectiveness of our intervention, the different tools that we have, or the different ingredients I think that we have in trials that we notice, is that some of the changes we see before and after treatment relate to artifacts, in the sense that we might be using tools to measure outcomes that are not super precise, and therefore we might notice differences just because the tool is not good enough. A bit like in the morning, if you go on your scale, you try to weigh yourself on your scale, and you notice that you are maybe half a kilogram lighter than the day before. Maybe it's true, or maybe it's the scale itself that is a bit dodgy and not being that specific. So that happens in clinical trials, and that's part of the change we might notice. There's this element of regression to the mean, which is the fact that if we look at symptoms which are persistent, it's likely that the patients are going to call us when they are the worst. And maybe without doing anything, within 10 days, they would, wave down a little bit before going up again and down and up and down and up and down. So they might, come for treatment when they are their worst, and there would be a sort of natural history of going down again before going up again. We know that the non-specific effects, like mentioned earlier, or contextual effects, they used to be called placebo effects, that relate to the therapeutic alliance, the therapeutic environment in which we practice, our reputation, the way we dress, the way we're able to provide patient-centered care, and all the different aspects is a huge part of our overall effectiveness. And finally, the specific effects are a part of what we deliver. This model I'm showing you assume that all the different effects can be added to each other. And that is currently disputed. And there's this idea that one impact the other one. What I mean by that is it's mostly from pharmacological studies that we know that. but it's there from pharmacological studies. There is evidence suggesting that for a molecule to have non-specific effects, it first needs to have some specific effects, which in a way sort of makes sense. It means that if you take ibuprofen for your headache, for example, if you start feeling the headache getting a little bit better from the drug, you must start thinking, oh, that's an amazing drug. And then you have all the non-specific effects coming on into that. So this idea that non-specific effects and specific effects are completely separate from each other is probably not exactly how it works. They sort of overlap and they are intertwined and they feed each other. Saying that, using this this image, and that's where the evidence is saying at the moment, in manual therapies, so it's not specific to osteopathy, that's in manual therapies overall, the specific effects of our intervention is between 20 and 35% of our care. So it's 19% for acute pain and 34% for chronic pain. So again, if we go back, we use that and we look at the trial where they compared osteopathic treatment with sham treatment, we notice that, you know, we are trying to measure maybe a difference that is only a fifth of the overall effectiveness of osteopathic intervention. So we shouldn't see that as a trial saying that it doesn't work. We are just measuring one ingredient, you know, in part of so many other ingredients. So that's why I think it's really important to be clear in our head when we read a paper. Are we looking at the overall effectiveness? Are we looking at the efficacy of just one ingredient? And what does it mean in patient care? And finally, before taking any questions or comments, if you want to follow us and to have any updates, we try to put info on social media as regularly as we can, and you can follow us on Twitter, Instagram, and Facebook. Thank you very much for your attention, and I'm very happy, or we are very happy to take any questions you might have or any comments.
We can't hear you, Martin.
Oh, sorry. Thank you very much, both Carol and Jenny, for a very interesting talk on these subjects. Yeah, I found it very useful as a review. Certainly, the Cauda Equina, Carol, was very interesting to go through again, and to hear the